Hello, this is Dr. R.D. Kavanaugh, and I'm going to be speaking at this Rheumatology Highlights report on the topic of new and emerging biologics. And as you will see, we'll focus a good amount of attention on new developments in the inhibition of IL-6. The objectives: to describe some of the recent data, including that presented at the EULAR, the European League Against Rheumatism meeting that was held in London earlier in the year, on inhibition of IL-6, on the clinical signs and symptoms, as well as quality of life in patients with rheumatoid arthritis, to talk about some safety issues that may be related to inhibition of IL-6, and then to identify some novel approaches to IL-6 inhibition. So there has been a good deal of interest in IL-6 as a potential target in autoimmune disease. And what you see on this slide is that the activities of IL-6 are many, and also of relevance is that many of the activities that can be achieved by this inflammatory cytokine relate to aspects of the immune system that are important for diseases such as rheumatoid arthritis. Toward the future, we may see the other diseases in which IL-6 may also play a role, but a lot of attention to date has been in rheumatoid arthritis, where the ability of IL-6 to activate B and T cells, to activate osteoclasts, which of course are important in damage into bone, including periarticular erosions, activation of the endothelium within the synovium and the synoviphytes themselves. All these activities can, in theory, contribute to the pathogenesis of this systemic inflammatory autoimmune disease, rheumatoid arthritis, and therefore IL-6 inhibition has theoretical appeal as a therapy. A lot of the data so far looking at IL-6 inhibition has come from the anti-IL-6 receptor antibody tocilizumab. There's been a lot of data with tocilizumab, which is now approved in many countries around the world for the treatment of patients with rheumatoid arthritis. A lot of data from clinical research studies, and now also beginning to get data from actual time in the clinic. There was an abstract presented at EULAR in 2011 from the Danish group, from the Danish Biologics Registry called DanBio. And this is interesting, I think, because it's some of the first data that we're seeing with tocilizumab as it's used in the community. So the DanBio is a registry in which patients in Denmark who are treated with biologic agents have their data collected. And these are not study patients. These are patients treated by rheumatologists across that country. So we know that sometimes the registries give us distinct information from that available in clinical studies. They tend to include larger number of patients. They tend to include patients who have a variety of comorbid conditions. So it gives us good information on what many of us would think would be real-life situations. In this, what we see is a number of patients, about 150 patients treated with the T-cell inhibitor abatacept and 178 treated with tocilizumab, to see how long patients stay on drug, and then also to see some efficacy outcomes. So overall, about two-thirds of the patients were still on drug over a year. And in real life, of course, patients vote with their feet. So staying on a drug is indicative that the drug is being tolerated well enough and also having good efficacy. And here you also see some of the outcome measures, the decrease in the joint counts, decrease in the C-reactive protein, which of course is very dramatic with tocilizumab, as we have learned from the clinical studies of that drug. So it's interesting data in that it's real-life data now from a registry looking at tocilizumab, since we've had this drug available to us in the clinic in some countries for several years. And this is the kind of data we'd like to see to get longer-term experience. There still are ongoing studies of tocilizumab. One that was presented was the study called ACT-RAY. And in this study, patients who were on methotrexate, who were incomplete responders, had tocilizumab added in addition to the methotrexate, or had tocilizumab added and then the methotrexate withdrawn. So it answers the question, someone who's not doing well on methotrexate, should you add the biologic, in this case the IL-6 inhibitor tocilizumab, or should you just switch and stop the methotrexate? So the data would seem to indicate that you can perhaps do pretty well with the monotherapy, meaning switching from methotrexate to tocilizumab, although the outcomes in general were a little bit higher with adding it to methotrexate. Now, I think this is very relevant, very important. In the clinic, we're used to talking with our patients about if you're on methotrexate and then we want to go to a biologic, particularly TNF inhibitor, we like to add it, and there's data that supports the synergy there. However, not all our patients like to take methotrexate. Therefore, if it was really no difference, might they be able just to switch to the biologic and stop the methotrexate? This data would suggest that both strategies work and that maybe you get almost as good data, if not as good data, just by switching. Of note, also, the tolerability was, if anything, a little bit better by switching. So there was a little bit more of a signal in terms of abnormalities of liver functions in those patients who remained on the methotrexate and then had tocilizumab added. So also of relevance. And I think this kind of information may help us as we think about presenting options to our patients when we're making therapeutic changes, and now getting data specific for inhibition of IL-6, in this case with the tocilizumab. At EULAR 2011, there was a follow-up of a study which generated a lot of excitement, in fact, led to an approval for IL-6 inhibition with tocilizumab for systemic onset juvenile idiopathic arthritis. And that was based on data from the TENDER study. The exciting data from that was presented last year and published, and as I say, has resulted in approval of the drug for that indication in some countries around the world. This is the longer-term follow-up of that. So there was a 12-week double-blind placebo-controlled portion, followed by an open-label treatment. The patients received pretty high doses, as is common for children, because it was based on pharmacokinetic modeling, and also in systemic onset JIA, they seem to really need the higher doses. Now the patients are being followed at the doses that they received in the active treatment, or if they got the placebo based on their weight. The primary outcome is the ACR 30 response specific for juvenile idiopathic arthritis, plus the absence of fever, which is important for systemic onset JIA. The week 12 responses were very dramatic in terms of the active treatment over what was seen with the control. Now, through 1 year, there's no more placebo control, but very high levels of response are seen. So good responses were seen early, even higher levels of response are seen. And the safety profile is as shown. There were some serious infections, some neutropenias, there were deaths. One was a motor vehicle accident, and one was a pneumothorax. So we certainly think about safety and tolerability. Remember, these children who had very severe disease, and the efficacy results are quite notable. So we have to balance the safety concerns with the potential benefit in a group of patients with a very severe disease. So there's been a lot of excitement on inhibition of IL-6, and of course, with the excitement and with proof of principle comes interest in looking at additional ways to approach the same target. And there's been a lot of work looking at blocking IL-6. Now, there are a number of ways in which this can be done. Tocilizumab is an antibody to the IL-6 receptor. There are additional antibodies that are being developed that also target the IL-6 receptor. However, targeting IL-6 has also been looked at, and from preliminary data, it looks as if that might be as viable and actually may be quite similar to what you see with inhibition of the IL-6 receptor. There was a study that was presented last year, a compound made by the company Alder, which is now being developed also with BMS, and you see the numbers of the compound at the top. It's a monoclonal antibody directed against IL-6, not at the receptor. This is the data that was seen from a study of intravenous administration given every 8 weeks, different doses of the IL-6 inhibitor in patients who had active arthritis despite methotrexate. And what's notable is a very clear distinction in the ACR 20, 50, and 70 from active treatment and the placebo. So it appears quite effective. There have been a couple of developments with this particular compound, several of which were presented at EULAR in 2011. One is that there's a subcutaneous formulation that's being developed. The initial studies were done intravenously, and I think most clinicians would say that the patients, if given a choice, would prefer to have a subcutaneous administration, or at least many of them would. Therefore, it's good to have that as an option. And the proof of principle has shown that you get acceptable pharmacokinetics with that. Also, there's data presented on quality of life. And as we have seen with tocilizumab, successful inhibition of IL-6 does result in improvement in quality of life. So this looks like a viable target as well, and it's very interesting to see this proceed in development. A lot of things in development in IL-6, and you see sort of a multiple potential agents at this. There was one that was presented, it was really very early, not even in human studies now, but I think it's interesting from a scientific standpoint. When you have something that has a complex interaction such as IL-6 does with IL-6 receptor, GP30, and the dimers of those that really form a hexamer to signal, you can get into theoretical discussions about might you be able to block systemic inflammation and leave aside physiologic functions of IL-6. And there was a development of an antibody to IL-6 that tried to look at that. And I think we'll see this, and it'd be interesting from a hypothetical standpoint. Inhibition of IL-6 by various means might give different results. So far, it appears that the efficacy and the safety and tolerability of those compounds that are further in development seem to be pretty similar, but there is the possibility perhaps of inhibiting IL-6 in a little bit different way that might give us perhaps better efficacy with less safety concern. And you see, here are some of the compounds. Some of this was presented at EULAR in 2011. We look forward to more of it being presented at ACR in 2011 and other scientific and congresses to come. It's an exciting area, and I think we'll certainly see more ways to skin this cat and perhaps more drugs come to the clinic. I mentioned tolerability, and of course that's always an issue with any drug that inhibits the systemic inflammation of rheumatoid arthritis. With IL-6, there are things that we think of, some of those common with other immune modulating or immunosuppressive agents, some that seem to be not unique but specific to IL-6, and that is elevations in liver function tests, decrease in neutropenia, and both of those seem to be dose-related and happen more right after a dose than they do for delayed time periods thereafter, for example. Increase in lipids, smaller incidence of decrease in thrombocytopenia. So tolerability issues, the more data we have, the more we learn. And I think as we have additional agents, it'd be interesting to see, will we end up more or less grouping them as we tend to do for the TNF inhibitors, or will inhibition of IL-6 by those different mechanisms that we spoke of give some safety issues that might be different among the different compounds? So definitely a hot area, and one that we look forward to in the future to provide us with even more information and hopefully additional therapies for our patients. Thank you for listening and watching.